Right, you should be good to go.
Yeah, we are live.
Okay.
Good evening, ladies and gentlemen. There's still quite a few people joining. I'm just going to give another minute and a half and then we'll get going. Right. Good evening, ladies and gentlemen. My name is Chris Foster and I have the privilege tonight to introduce Dr. Tumelo Satekge to you. Dr. Tumelo is a medical practitioner who graduated from Wits University in 2011. In 2020, Dr. Satekge became a qualified chemical pathologist specializing in pediatric laboratory medicine with a focus on rare diseases, particularly inborn errors of metabolism. Dr. Satekge has presented at international congresses on various aspects of pediatric laboratory medicine and inborn errors of metabolism. Notably, Dr. Satekge has published research on screening for galactosemia, which has really become a landmark article in South Africa, in a tertiary laboratory alongside case reports and other research publications. Dr. Satekge has also received training in the laboratory aspects of genetic and metabolic diseases. Tumelo, so as I have it, you're going to present to us on the approach to a patient with dysmorphology. I look forward to your presentation and the floor is yours. Thank you.
Thank you so much, Prof. Foster, for the kind introduction. So I can imagine it was a bit surprising for most of you as to why a chemical pathologist is presenting on dysmorphology. But actually the topic is dysmorphology and lysosomal storage diseases. So lysosomal storage diseases is part of inborn errors of metabolism, which is the area of my special interest. So I actually did a talk a few years ago looking at dysmorphic features and inborn errors of metabolism. So it was quite lengthy and complex. So I was relieved to learn that I will just narrow it down to lysosomal storage diseases this time. Doesn't make it any easier, but we'll see how it goes. So this is the outline of my talk. So I also just want to share with you some MPS2 cases summaries, as well as our experience in Limpopo with regards to IMDs. So basically just be sharing with you what we are diagnosing and what challenges we are facing. So as an introduction to this dysmorphism, so if you break the word dysmorphic, it comes from the Greek term whereby dys refers to disordered and morph is shape or form. So if you have to take this, and then we come up with a definition for dysmorphism, it will be variation in body structure as compared to what is considered to be normal in inverted commas. So it's in inverted commas because there's a huge variation. So what I consider normal, it may be abnormal to the next person. That's how subjective it is. So dysmorphology is it's a branch of genetics where clinicians and researchers, they study and interpret patterns of human growth and structural defects. So dysmorphology, it actually encompasses the study of dysmorphic features, their origin, and to ensure that there's proper nomenclature being used for the different dysmorphic features. So as a result, there's actually a super specialist called clinical dysmorphologist, which actually practice the science of dysmorphology, which can actually be fascinating. So one in 40 infants will have some sort of will be born with some sort of malformation. These were related to congenital disorders or some genetic syndromes, and up to 4,000 malformation syndromes have been deleted thus far, which is quite a lot. So these are mostly craniofacial as well as skeletal features such as clubfoot. So dysmorphic features generally are evaluated by clinical geneticists or pediatricians, particularly neonatologists. So this dysmorphic features can actually be a concern and anxiety for parents and physicians. So you can imagine expecting parents who are happy about the bundle of joy, only to find that when they are born, not all is well with the little one with this dysmorphic features. So it can actually be distressing for the parents. As you can imagine, the first interaction with the baby is actually on the face. That is after checking the sex, of course. So you can imagine if there are some severe dysmorphic features malformation, can actually cause anxiety to the parents, as well as the physicians, because the physicians have to counsel and reassure the parents while they try to establish the cause of the dysmorphic features. So it is also important to differentiate normal features due to prematurity. For example, you can have a soft ear cartilage, which presents as an unusual shaped pinna, which can just be as a result of the prematurity, not necessarily an abnormal finding. And things like edema, as well as mechanical pressure, for example, from uterine malformation, can also result in some transient dysmorphic features, which will resolve in time. So the dysmorphic features are quite dynamic. They change day by day. And some of them, they need to be considered in the context of family features. You may find that some of the features, they are not really abnormal, but they're actually a normal variant in the family. So documentation is quite critical. And then some doctors actually, they prefer to take videos, to take pictures as sort of as a medical record, which can also be very important. So the documentation is quite important because of the day-to-day changes. So the small features can present, some of them present at birth, but others can occur later in childhood, for example, with Lazarus disease, which is what I'm going to talk about today. So an approach to baby with dysmorphic features, so this will require detailed history. That will include family history of consanguinity, and parental history will also be important. So exposure history is also important. For example, exposure to alcohol can result in fecal alcohol syndrome, which can present with prominent dysmorphic features. So this will be followed by meticulous clinical examination, and then thereafter you're able to postulate the signs, and then with that, then you should be able to sort of recognize a pattern. And then hopefully this pattern will sort of narrow down the differential diagnosis, which will propel you to appropriate investigations. So just on basic genetics, so we'll know that our genetic information is actually imprinted on our DNA, and it exists as 4 nucleotide bases, 4 nucleotides which form a basis and form this helix structure. So the DNA, it interacts with some proteins called histones, which then forms what they call nucleoproteins, which then condense to form nucleosomes. The nucleosomes form chromatids. And then from chromatids, they are packaged nicely in the nucleus. And then looping of these chromatids, they form the chromosome. So problems with patients with dysmorphic features, they can either occur at the level of the chromosome or at the level of the DNA, for example, with inborn metabolism, which I'll get into. So chromosomal disorders or aneuploidies, so these are the common causes of dysmorphic features, of which trisomy 21 or Down syndrome will be the most commonest, followed by trisomy 18, then trisomy 13. So trisomy 18 and 13, though less common, they can present with severe malformations, generally having a worse prognosis. And then you have macrodeletion syndromes. So these are deletions which are too small to detect with conventional karyotyping. So these patients will actually, the investigations will require chromosomal array, for example. So examples, there will be Prader-Willi syndrome and Dye-George. And I must say that in Limpopo, we have diagnosed quite a number of patients with deletions and duplications as a result of the chromosomal array from the NHLS. And just to give an example, for a patient with Barakat syndrome, which was diagnosed by a chromosomal array. Okay, so So just submitted the manuscript for publication. So this will be the first case of Baraka syndrome to be diagnosed by chromosomal array in Africa. So for the purpose of this talk, we'll be focusing on inborn errors of metabolism, which are single gene disorders. So inborn errors of metabolism, so this way you have a genetic variant that will result in a deficiency of an enzyme. It can also disrupt other proteins, such as transport proteins. Okay. So as a result, then you get a metabolic block. From the metabolic block, then you get accumulation of substrates as well as lack of products. Okay. So it is the accumulation of substrate that actually makes the patient sick or symptomatic. So there is a link between dysmorphic features and inborn errors of metabolism. Okay. So dysmorphic syndromes can be considered as a result of biochemical defects. So with this, with research of multi-omics, particularly metabolomics and genomics, we discover more information on the molecular and biochemical mechanisms and pathway. So basically, so the biochemist will say that in disease-causing genetic variant, there should be some biochemical pathway, okay, resulting from that genetic variant. So meaning that we can actually have metabolic pathways in the form of inborn errors of metabolism being affected, resulting in dysmorphic features. So, but what we know is that the inborn errors of metabolism that present with dysmorphic features, they are the ones that involve large complex molecules. So these present as multisystemic and major organ malformations, for example, lysosomal storage disease, which is the topic for today. So lysosomal storage disease, so they occur because of deficient catabolic enzymes within the lysosomes. And as a result of this, there's accumulation of specific substrates. So there are more than 50 lysosomal storage diseases that have been described thus far, which was quite amazing because this is quite a lot, because most of us we only get exposed to a fraction of these more than 50 LSDs. So many steps are necessary for the synthesis and processing of lysosomal enzymes. And because of these many steps, there's many opportunities for things to go wrong in synthesizing these enzymes, resulting in the deficiency, causing some lysosomal storage disease. So generally, they appear normal at birth, so meaning that the dysmorphic features will not be immediately apparent immediately after the baby is born. So they tend to occur later in the childhood. So LSDs, they are multisystemic and they are progressive over months, and they can actually take even years to manifest. So these are the LSDs that I have selected to talk about. So these are the ones that actually are linked with dysmorphic features. So the first condition I want to talk about is mucopolysaccharidosis. So in mucopolysaccharidosis, there is failure to degrade glucose aminoglycans as a result of the deficiency in the enzymes. Okay. So there are 11 MPS types. So they present as a continuum of clinical manifestations, which involves multiple organs. So we divide them into the severe, rapid progressing, which tend to occur earlier in life, okay, mainly in childhood. And then for the attenuated and slowly progressing, which tend to present later in life, late onset or adulthood. So what are glycosaminoglycans? So glycosaminoglycans, GAGs, so these are disaccharides that are modified. So basically these are carbohydrates that are modified. So modified in that they contain a sulfate group as well as glucosamine group. So then what happens then in the lysosomes, these complex glycosaminoglycans need to be degraded. So they get degraded by using multiple enzymes. Okay. So these enzymes, it involves a sulfatase. What it does then, it just removes the sulfate group there. And then it is followed by a glucosidase. What the glucosidase does, it breaks the glycosidic bond there. As a result, then the molecule becomes shorter. So this another sulfatase, it removes the sulfate group, and then it repeats until you get a smaller molecule there. So these are just examples of the GAGs, which is dermatan sulfate and heparin sulfate, and those are the enzymes that are involved. So deficiency of these enzymes result in the various types of MPS or mucopolysaccharidosis. So the one that we see commonly in our setting will be MPS 2, which is X-linked recessive. So mainly boys will be affected, okay? So what happens then with MPS 2, there's deficiency of this enzyme, okay? And as a result, we're unable to degrade these molecules. So as a result, the dermatan sulfate and heparan sulfate will be elevated, which is part of the screening that we can do. So mucopolysaccharidosis and dysmorphic features is quite important. I think MPS is one of those patient cases where we just only have to see one, and they get stuck with you, and just don't forget, and it becomes so difficult to miss the next one just because of the typical features that they present with. So these are their features. So they present with coarse facial features, and actually you can actually feel the texture of the skin, how coarse it is. Okay. So it also presents with macrocephaly, which you can see in this patient, craniosynostosis. So basically, this is a premature fusion of the sutures, the same way that we get with rickets. They get dry, coarse hair, they got these thick lips, enlarged protruding tongue because of the deposition of the gags. Hypertrichosis means extra hair on their bodies, prominent supraorbital ridges, depressed nasal bridge, broad nose and flat nostrils, low set ears, full round cheeks, short neck, as you can see, as well as skeletal deformities such as contractures, genu-valgus and varus feet, as well as the short and stout claw hands. So these occur as a result of the joint stiffness as well as the joint contractures. So this is just to say that the MPS doesn't only affect doesn't only cause dysmorphic features, it actually causes vast array of clinical features, which I've just highlighted here. So this has to, so you can classify them into the severe or the mild, where you can see that the severe ones, they tend to have severe manifestation of the clinical signs, and then they tend to happen in childhood. While the milder ones, they tend to be less mild. So just to highlight that Hunter syndrome, which what you see with MPS 2, it actually presents with most of the clinical features which you'll be able to see in a patient. And as you can see, that it does result in death. And in most cases, the severe one will die in childhood. And then another thing, that the reason why they die is because of cardiac involvement. So cardiac failure is one of the reasons why we lose these patients. So I'll be quoting some publications in South Africa during the presentation. So for MPS, so these are the publications that we have from South Africa. So this is the first publication is from this family whereby the brothers were affected. They had MPS 2 as well as the uncle as well. The grandmother is X-linked, so the males will be affected. So you also have this our publication here, which speaks about Hunter syndrome associated with severe cardiac lesion as a result of a novel variant, which I'm going to talk about a bit later in the presentation. So the next LSD I'll talk about is Gaucher disease. So it occurs as a result of beta glucose depositase deficiency as a result of variants in the GBA gene. Okay. So this enzyme, it degrades glucoceramide. So it means that if it's deficient, then there'll be accumulation of glucoceramide in the macrophages, resulting in the various types of Gaucher. So there's three forms that we get. There's the non-neuronopathic, which is the milder form because it doesn't have neurological symptoms, and then got the acute one. So this one is quite severe. Fortunately, it's quite rare. So this presents in early childhood, and then there's a rapid progression of neurological symptoms. And then the chronic one is the adult onset, which is the mildest. So it presents with a broad spectrum of multisystemic clinical phenotype, meaning that it can actually cause an overlap. There's an overlap between the three types. So it's not really clear cut with regards to the different forms. So Gaucher's disease, the dysmorphic features that we get, so it can cause low set ears, small nose, flat nasal bridge, microcephaly, hyperthyroidism, so microstomia means a small mouth opening, everse lips, macrognathia, that's underdeveloped mandible. So ichthyosis, so this is the picture of ichthyosis. So it's basically is a dry, scaling and very itchy appearance of the skin. And this occurs as a result of the disformation of the epidermis. So basically, it's like the skin is peeling off. So you see this mainly with the type 2, the severe one. And it also gets skeletal disorders, this just means the multiple contractures. So that's what we get with Gaucher disease. So when it comes to publication of Gaucher in South Africa, there's this publication also talks about the patients affected in the indigenous population. So this publication talks about 19 patients. So all of them, they had type 1 Gaucher, which is the milder one. So just know that actually these patients, they were diagnosed by a bone marrow biopsy because they didn't have neurological symptoms. But what is interesting is the variant that was picked up in the study. So they picked up this variant, which was found to be, so almost all 19 patients, they were heterozygous for this variant, which has a carrier frequency of 1 in 66. So it's probably quite common in our patients. And this resulted in milder disease. And there was also this second commonest variant, which is the recombinant allele, which is basically the unequal crossover of the with the pseudogene just nearby near to the GBA gene. So there's also this publication from long ago, 1979. So basically looking at Gaucher disease in South Africa, but actually it was looking at the Jewish population. So you will know that Gaucher is actually most highly prevalent in the Jewish population. That's why you can see the carrier frequency is much higher compared to the African population. That was the estimated prevalence on the Jewish population in South Africa. So the next condition will be Fabry's disease. So it occurs as a result of deficiency of the galactosidase, alpha galactosidase, due to variants in the GLA gene. So as a result, we get accumulation of lipotriaceramide. So it is an X-linked recessive disorder. So basically, it is the second most common LSD after Gaucher. So it also has two types, type 1, the classic form, which is the severe form occurring in early childhood, as well as the atypical late onset form. So Fabry disease can also present with dysmorphic features, which include periorbital fullness, which can give you an impression of these small eyes because of the fullness around the eyes. So they can also have recessed forehead, full lips, prominent ear lobules, which you can appreciate here as well, prominent supraorbital ridges, bushy eyebrows, prominent nasal bridge, acute nasolabial angle, corneal opacities, shallow mid-face. So in a normal situation, you would expect the nasolabial angle to be at an obtuse angle or more than 90 degrees. But in the affected patient with Fabry's disease, then the angle tends to be more acute or close to 90 degrees. So that's one of the ways you can actually distinguish Fabry's disease. So the next condition is Pompe, which occurs as a result of acid alpha glucoside deficiency due to variants in the GAA gene. So this enzyme is responsible for the breakdown of glycogen in the lysosomes. So it means there's deficiency, then you're going to get accumulation of glycogen in the lysosomes. That is why we also refer to it as a glycogen storage disease. I think it's type 2. So it's called two types. It's called the infantile form, which is the classic infantile form. So here they have severe cardiac involvement. The infantile variant, then this tends to be more skeletal problems, less cardiac. And then the late onset, which you see mainly in the adults. So this tends to progress much, much slower, and they don't have cardiac involvement. So Pompe disease key clinical features include cardiomegaly, which includes cardiomyopathy, hepatomegaly, myopathy, as well as hypotonia. So it doesn't really give much when it comes to dysmorphic features, but it's worth noting that it can give you, most articles, they report on macroglossia. So it means it's an enlarged tongue as a result of glycogen deposition. And then I think one case report had some flattened nasal bridge and facial hair. So this is the variant that we mainly see in the African, in the population of African descent. So when it comes to publications from South African Pompe, just this mini review that looks at the diagnosis and management of Pompe disease. So basically just how you'll be able to diagnose or investigate Pompe in the NHLS essentially, and how you manage it. But what's interesting is this article whereby this case report, so it was published in Madrid. So this case report, this patient actually was found to be homozygous for this variant, and only to find that actually the parents they originated from Nigeria. Okay? So this is why it's worth noting this variant seen in African descent. So also you won't be surprised if you also have this variant as well in South Africa. So the next condition will be galactosialidosis. So this occurs as a result of primary defect of the cathepsin A, which is a protective protein. So it occurs as a result of genetic variants in the CTSA gene. So it also has some secondary effect where it disrupts a lysosomal multi-enzyme complex, which include the beta-galactosidase as well as neuroaminidase 1. So we've got the two types, which is the early late infantile. So this is the one that we present mainly with cardiac problems, renal problems, early in childhood, and the juvenile adult type, which tend to progress much slower. So galactosialidosis is also very important because it can give you some dysmorphic features, which include bilateral epicenter inferior orbital creases, absent nasal septum, molar hypoplasia, high arch palate, underdeveloped mandible, long philtrum. So basically, this is the groove in the upper lip, sparse temporal hair, cherry spot, which you can see on fundoscopy, cloudy cornea, bilateral cataract, so as well as angiokeratoma. So this is a picture of angiokeratoma. So it's essentially a small raised purplish rash, which you get with this condition, but you can also get it with Fabry's disease as well. So the next condition, it doesn't really cause much in terms of dysmorphic features, but it is worth mentioning because it is quite prevalent in South Africa in our context, based on this article here. So the condition is cystinosis. So it occurs as a result of the genetic variants in the CTNS gene, which encode a protein called cystinosin. So this protein, what it does, it actually transports cysteine into the cytoplasm from the lysosomes. So therefore, if we don't have this protein, it results in defective transport, whereby cysteine will accumulate within the lysosomes, and these patients really become sick. So they present with failure to thrive. They can also get hypophosphatemic rickets. So what happens in this condition is that they get proximal tubulopathy, which can actually mimic Fanconi-like pictures. So because of that, then they get phosphate wasting in the kidney. They can also get bicarbonate loss and can also get amino aciduria as well because of that proximal tubulopathy. So they also have significant hypophosphatemia, which can present as rickets. So this tubulopathy then will progress to end-stage renal disease or end-stage renal failure, and they also have severe myopathy that these patients won't be able to even walk. They also get hypothyroidism because of deposits in the thyroid glands, and they also get corneal crystals, which you can see here. So basically, these are the cystine crystals in the cornea, which you can see well with a slit lamp with ophthalmology. So all these patients in this article here, they all tested positive. They were actually homozygous for this variant. Okay, so basically this is the cause. So so it results in a frame shift after an insertion at this position here. So this results in a nephropathic infantile type, which is the severe form, which we see commonly. So it doesn't really cause dysmorphic features, but I think it is quite an important lysosomal storage disease that we must actually know something about, particularly in South African context. So this miscellaneous cause mevalonic aciduria, which can cause prominent dysmorphic features. So it can cause a microcephaly. It can cause the dolichocephaly, which is just abnormal narrowing of the head. Low set and posterior rotated ears, which I'm sure you can appreciate it, and then down slanting of the eyebrows, blue sclera, and as well as cataract. So these are the conditions that we need to sort of, it's quite rare. So the reason I mentioned it is because we have this publication of a patient with mevalonic aciduria. So So basically, this is a patient that presented to Steve Biko Hospital with workup for chronic liver disease, also with conjugated hyperbilirubinemia, and then the patient also had failure to thrive. What's also of note as well is that this patient had these multiple febrile episodes. So torches was done, torch screen was done. Then what they found that cytomegalovirus was positive with a high viral load. So then they thought maybe this presentation was thought to be due to a simple infection. So they treated with ganciclovir for 2 weeks, but the symptoms persisted. So then what they did the liver biopsy, okay? And what the liver biopsy showed, it showed some alpha-1 antitrypsin positive granules in the hepatocyte, the cytoplasm. So this was indicative of alpha-1 antitrypsin deficiency. So then what they did the alpha-1 antitrypsin levels, they found to be normal. Then they even did the genotyping for alpha-1 antitrypsin deficiency, which also came back normal. So then they were stuck. Then they didn't know what to do. So then the gastroenterologist said, then let's do organic acids and see if it can help. So what they with the organic acid, then it shows a highly elevated mefonolactone, which was then repeated. So that mefonolactone, after it being done, then obviously this was suggestive of mevalonic aciduria. Then we did the sequencing of the MVK gene, which confirmed mevalonic aciduria. So, but what happened at the time this result came, the person already succumbed to the disease, okay? So the take-home message here is to say that we always think about common things occurring commonly, but at the same time, conditions like these ones, they tend to be considered much later. And the time they consider them is at times too late for the patient. And just to say that this condition, if you look at the literature, it's very rare. It's like it goes 1 to 3 in a million. So it's quite a rare condition. But then able to make a diagnosis. And by the way, this sequencing was done by the NHLS, University of Cape Town. So basically, even in the NHLS, we are able to confirm these patients with incredibly rare diseases. So I cannot talk about dysmorphic features and not mention the phase 2 gene. It's quite popular, and I think it is really useful. So the phase 2 gene is a suite of phenotype applications that facilitate comprehensive and precise genetic evaluations. So basically, it just basically presents as an opportunity for enhanced patient evaluation with next generation phenotyping. So it's able to detect some phenotypes, including the dysmorphic features like the facial ones, but even the non-facial features as well, it can also be able to detect. And then it will review the relevant syndrome matches, and then it provides the access to best-in-class resources. So it is also interactive in that you can also have a collaborative case review for diagnostic dilemmas, and you can give feedback and also get feedback from this phase 2 gene. And I think most pediatricians are making use of it. So just basically, and also this review, I found it useful. It basically looking at the facial features of the different LSDs. And what phase 2 gene was able to do was able to distinguish the different LSDs just by looking at the facial features. So it can really be a useful tool, which probably we should be using. So now I just want to share a bit of experience, personal experience with regards to the MPS 2 investigations. So first of all, so basically we started investigating for MPS when I was still a registrar at University of Pretoria or Steve Biko. So this is the first patient that we diagnosed. So basically we start with a screening test, which measures the glycosaminoglycans. So if they are found to be elevated, then we'll do the fractionation to see which ones are elevated. So in this particular patients, dermatan sulfate, heparan sulfate were elevated. So this was followed by enzyme activity. So what happens there, they do a panel of various enzymes in LSDs. So you can see for this particular patient, the enzyme responsible for MPS 2 was found to be low, was found to be very much undetectable. So this was then confirmed by gene sequencing, which showed this variant, which confirms the MPS 2. So the second patient, similarly, you can see the dermatan sulfate, heparan sulfate significantly elevated. And then we did the enzyme activity, also found to be undetectable, significantly low. And then the sequencing, it showed this deletion of this basis, resulting in a frame shift deletion, whereby it results in premature termination. So because of this finding, it was classified as pathogenic, and then it was that was used to confirm MPS 2. So basically, this is the patient that we actually published. So with MPS 2, the cardiac abnormalities would expect some valvulopathy, can expect maybe cardiomegaly, can also expect some coronary syndrome effects. This is a result of accumulation of the glycosaminoglycans in these heart structures. But before you publish this case, there was this publication where it talked about MPS 2 with VSD, ventricular septal defect. So, which we found very interesting. So now our patient had a severe cardiac lesions in that he had a VSD as well as left main pulmonary agenesis complicated into Eisenmenger syndrome. And then you can see the left lung was hypoplastic, essentially because of this left main pulmonary agenesis. So we think that probably this severe cardiac lesion was a result of this variant we picked up here, which was just resulting in abnormal premature stop codon. So, but it also worth mentioning because we know that this patient MPS 2, the main reason we lose them is because of cardiac failure. And this is probably the reason that some of these patients, they may actually present with severe cardiac lesions, which which must always be on the lookout for. So then moving to Limpopo, then we also investigated more patients. So this is the first patient that we diagnosed from Limpopo. So you can see also the GAGs were high with abnormally elevated heparan and dermatan sulfate. So you can see the full panel of tests or enzymes that were done. Only one was abnormal, the enzyme responsible for MPS 2. So what is interesting about this patient is the variant that was detected, which was classified as likely pathogenic based on this criteria there, which you can see. Then the last patient we have diagnosed, it's also, as you can see, this one, I think we did the screening in the NHLS, and then the enzyme can see very, very low. So the variant that we see here is the deletion in some of these deletions of this bases there, and then resulting in that what you see there in the protein change. And what's also interesting here is how it was classified. It was classified as a VUS, variant of unknown significance, based on that criteria there. So basically, this is just a summary of the MPS genotype that we see, that we've seen in this patient. So just to highlight a few things. So you can just see the first two were classified as pathogenic, which probably makes sense with regards to the phenotype. So what is interesting here is this one that were classified as likely pathogenic as well as variant of unknown significance. So for us, this is interesting because if you have a patient that's got the typical phenotype of MPS, the enzyme activity is low. Can you really say that this classification is correct, given the presentation of the patient? So, and I think it just shows that we need to probably do more research on functional studies, okay, just to probably to reclassify this variants. I think what is also interesting here is that most of these variants, they were classified as novel. So basically, it was the first time that they were picked up. So they were not described in the literature before. So which is quite also interesting for us, because we know that the African population is underrepresented, is understudied when it comes to the genetic database. So this also provides an opportunity for us to do research, to sort of pick up these variants, publish them, so that we can give Africa a more representation. What's also interesting about this patient, I didn't talk about it, because this is a patient that has MPS IIIB. So he was diagnosed by colleagues at Satekge, but the patient now is following up with Polokwane. So what's interesting about this patient is that was diagnosed at 16 years. So you can imagine, so we talk about diagnostic odyssey, whereby it can really, really take a long time for patent rare disease to get to a diagnosis. And you can imagine what the journey could have been for this family to eventually get to a diagnosis. Yeah, so basically just a bit of the methodology as compared. So these are the tests that we use in the laboratory for investigations of MPS. So we start with the screening test, which is the methylene blue assay. So basically what it does, or dimethylene blue, so basically it creates complexes with the glycosaminoglycans, and then it gives you this colorimetric complex, which gives you this color spectrum there. So in this particular run, there was some control, there's some standards, as well as the patient samples. So you can see the beautiful colorimetric, the color spectrum there. So this was the screening test. If it's elevated, then you do fractionation by LC tandem mass spec chromatogram. And then we're going to see these huge peaks of heparan sulfate and as well as dermatan sulfate, which would then be followed by an enzyme activity. So basically, so these are the pictures courtesy of the CHM. So basically, I took this picture when I was doing my training there. I don't know how many years ago. So yeah, so we're able to do the methodology for investigation of the MPS patient. Oh, and this one diagram actually comes from that publication that I talked about with severe cardiac lesion. So just want to talk now about our experiences in Limpopo in terms of what conditions are we seeing. So basically the common conditions, we see galactosemia. So galactosemia, so these patients, they have a molecular diagnosis. So basically we do the sequencing for them, and they were all found to be homozygous for the African variant, the S135L. And these patients are doing well on galactose-free diet. And then we see 25 hydroxylase deficiency. This is presenting as congenital adrenal hyperplasia. So what also we do molecular testing for these patients. We do MLPA or sequencing of the gene. So what is interesting here, these patients, they tested, they had various variants that we detected. So there was no repeating variant. And most of these variants were actually deletions in the gene. And actually one of the patients presented as a precocious puberty in a male. So we are busy doing the write-up now, so we'll be publishing the case. Propionic acidemia, we have one that was also diagnosed, just confirmed by MLPA. So Mikopa Segurusa already mentioned that there's 3 patients. So what is also interesting that in Limpopo, there's about 13 patients, okay, of which the investigations came back normal. So now we don't know if these patients were considered for other diagnosis. Okay. So if not, it means this group is still undiagnosed. Primary hyperoxaluria, we also have one, and then MP17 neuropathy, very rare disease. So you've diagnosed one with the molecular test. So what's also interesting, these are the patients that do not have a definitive diagnosis. So these are the mitochondrial cytopathy. So these are the ones that tested negative for MPV17. So now we don't know which mitochondrial disorder it could be after excluding MPV17, because it's quite limited in terms of how far we can go. So other ones, fatty acid oxidation also. This is basically, we see this on the organic acid analysis, but then this patient didn't come back for acylcarnitine profile to be able to confirm if indeed they have the FAOD. Diagnostic disease is very difficult to investigate these patients. So these patients, they are for me, they're important because, so these are the ones that actually present very sick. And often what happens is that they don't give us enough time to investigate them because they quickly succumb to disease. So unfortunately, we can see quite a number of them that actually we lose them before even getting to a diagnosis. And then the others inconclusive. So these are the ones that we see a metabolite on the organic acid, like malonic acid, don't know if malonic aciduria, at times just isolate lacturia, but there's no sepsis, so we don't know if it can either be an underlying AMD or not. So from this picture, what I'm trying to show you is that there's a growing number of patients that are suspected with IMDs that are not getting diagnosis. So basically, there's no definitive diagnosis. So what we've been doing is that we've been raising awareness on IMDs. So as you raise awareness, then we're getting more samples that come, and then they get more requests. Then as we get more requests, we are unable to confirm the diagnosis because of the limited tests that we have. Okay, so it's a bit of a dilemma that we're facing. But at the same time, we found a solution for this in the form of a PhD project, whereby we will be integrating the metabolomics and genomics for of patients suspected with IMDs that are undiagnosed in Limpopo province. So this aim, it just seems, it may be fancy, but what we are saying here, essentially, we are trying to attain to get to a definitive diagnosis for these patients. You know, what is important here is just to go back to the parents and say, we finally know what's wrong with your baby. You know, is to tell them that we finally got a diagnosis, whereby we can even tell them what is the cause, because remember now with genomics, it means you got the genetic diagnosis. And you know this condition that results from a genetic variant. So you can actually even explain to that level that you actually know what the cause of why your child presented this way. So in this way, then you're able to offer them genetic counseling, as well as to bring closure. You know, some of these conditions are really devastating that we probably won't be able to treat them. But the fact that we go to a diagnosis, then we can just say, bring some sort of closure to say, we know what made your patient, what made the baby demise, for example. So this PhD project will be done under the Ingwe platform, which I'm sure Prof. Foster will mention a few things about. So, but basically here we are recruiting researchers, scientists, healthcare workers, you know, just to do something about undiagnosed rare diseases, essentially. So let me conclude by saying that dysmorphism can be distressing both to the parents, it can be distressing both to the physician who have to find a cause. So a meticulous clinical approach to dysmorphism, it could really be helpful in that from clinical history, from the clinical examination, getting to a differential diagnosis that will propose appropriate investigations. I think that will also help. So LSDs, I've shown you that it's an important cause of dysmorphism. But just to mention that it is not only LSDs that can cause dysmorphism. There are also other inborn errors of metabolism, such as peroxisomal disorders, CDGs, congenital disorder of glycosylation, which can also cause dysmorphic features. So I was also intentional about in the presentation that I mentioned some variants. So in these conditions, because we know that as we move towards molecular screening, we'll be able to make a diagnosis of this pain just by testing the common variants, which I'm sure are available in the NHLS and other testing centers as well. For example, condition like Gaucher's disease, it should no longer be diagnosed on bone marrow biopsy because it's quite invasive, it's quite painful. So if you can just do the common variant testing, you'll be able to make a diagnosis. So I've also mentioned that there's growing numbers of patients with rare diseases, probably IMDs, that are getting undiagnosed. And I think we can do something about it. Like I mentioned the PhD project that we're busy with. But working with rare diseases, I think it's very important that it becomes a collaborative effort whereby we just need to all get together, and do something about it. And this can be done on this Ingwe platform. So I just urge you to just take the pledge and join the community. So with that, thank you very much, and then I'll be able to take questions.
Thank you, Tumelo, for a very insightful and also very practical presentation that's, I think, extremely relevant to clinicians and scientists in South Africa. This is my first time that I'm hosting a presentation. Normally I just chair. So if I'm a little bit slow, just bear with me, please. You're welcome to start to post your questions in the question and answer section. And if you want to ask the question in person, then you're also welcome to just ask that you be unmuted, and then I will do my best to do just that. Tumelo, while we're waiting for questions, let me just make a statement, and just I just want to be interested to know whether you agree with me or not. So in the variances of unknown significance that you've mentioned, if we those variants are classified using Franklin online classification system, but we can also amend that to include phenotypical characteristics that will then change the classification from unknown significance to probably to likely pathogenic. However, if you sit in the lab and it's just one patient that you haven't seen, then I'm also always a little bit hesitant to do that. However, if we have the classic biochemistry, so we've got high heparin sulfate, high dimethyl sulfate, low to non-existing iduronate 2 sulfatase, do we really need the genetics to confirm the diagnosis? For many years we didn't diagnose them using genetics, and are we not, particularly in inherited metabolic medicine, are we not starting to over rely on genetic testing?
Yeah, it's quite interesting because the way we investigate our patients, I always place emphasis on the molecular testing, because we know that these conditions, at the end of the day, they are genetic disorders. Actually, the main cause is as a result of at the genetics level. So I think for me, I would say that it's probably more reassuring when you confirm the condition with genetic testing, because then for me it says that we've got a definitive diagnosis. But at the same time, because the lack of representation from Africa, then it becomes very difficult to interpret our variants. So I'll still place emphasis on the molecular testing just for the confirmation, and then look at probably reclassifying it at the later stage, maybe due to functional studies at a stage, or maybe just try to get more evidence. I know it's probably too much work. I mean, you work with this, and I'm sure it could be quite daunting. But yeah, for me, I think also for the purpose of genetic counseling and for the purpose of career testing for the parents and also siblings, I think for me, it's also important to just go all the way up to get to a definitive diagnosis by a molecular test. Though say probably to be interpreted with caution, in that probably to be difficult to interpret according to the criteria for correct classifying it.
Thank you. I think you've made some valid points there. Herbert Makopa is saying, excellent presentation. Thank you, Dr. Satekge. Then Sibongile Mbata, how did your metabolic encephalopathies present? We have had a few and have not managed to diagnose them.
Yeah, so these are the patients that they present with hypotonia, lethargy, poor cry, not tolerating feeds, severe encephalopathic. So basically, these are the consults that you get. It says, I've got a baby that is severe encephalopathic with high anion gap metabolic acidosis. And then what he also said that he says that prognosis is guarded, So when I get that sort of picture, then probably then you're thinking of metabolic encephalopathy. But what we have also done, we just said after bringing the urine, we just also advise the doctors to just also take extra purple top at that time, because you know that there's a high chance we're going to lose the baby. So if we take a purple top at that time, so what we can do is that when the organic acid test comes, then we know that we've got EDTA sample that is available to do the testing, to do the confirmatory testing. So in terms of the organic acids, also some of them are really inconclusive. Some of them, they suggest that it could be underlying mitochondrial disorder, but then obviously we'll be unable to confirm. But sometimes even the organic acid becomes so vague, so that I don't know what you can do. So I think what we'll do is probably will benefit more from whole exome sequencing, I think, because it's such a complicated presentation, but we know that probably it's an underlying imbalance in metabolism. Probably whole genome sequencing will be more informative to go to a diagnosis.
Right. Okay. Alice Lainza is asking, frontal bossing is very common in African families. Is there a scientific basing for this other than telling our kids that they are clever because they have a big frontal lobe? Most of these kids are quite clever too, tongue in the cheek.
Wow, yeah. I think this one it's meant to be for pediatricians. Yeah, so I mean that's why I know with dysmorphic features they are highly subjective, and then there's also be a normal variant, so the presence of a certain feature doesn't necessarily mean that is a problem. It could just be a familial thing. Maybe but parents are also have frontal bossing, so basically I think the clue there will be just to look for other features in the child, to see if there could be other features that could, such things like thalassemias can also result in frontal bossing, just to do a comprehensive examination to rule out, like I mentioned, the pattern, look for a pattern. If there's a pattern to suggest a certain syndrome, then you'll follow that way. But if they're just frontal bossing, probably you can just reassure the parents, as it is a gift in that they are quite intelligent.
Okay, Ulauku Nso Ezima is asking or saying, thank you for an elaborate presentation. In setting where LC-MS is not available, are there other biochemical investigations that can be used to make a diagnosis?
That is for MPS II. So basically, the fractionation, you can also use electrophoresis as well as thin layer chromatography. I think the NHLS, they do their fractionation using electrophoresis, if I'm not mistaken. So yeah, LC tandem mass spec is quite a very expensive technique. It can also require expertise, but you can also do the fractionation using TLC as well as electrophoresis. Though I must say that probably the sensitivity and specificity won't be as great as you'd get with LC tandem mass spec.
Okay, Caitlin Cutler is asking, are dysmorphic features judged based off ethnic background? What is normal for some of European ancestry might be abnormal for someone of African ancestry. And I think important point there also is to keep in mind when using phase-to-gene. So what's the state on that? Is phase-to-gene really diagnosing these conditions in African patients?
Yeah, sure. That's an interesting one. And I think probably the pediatricians or geneticists that have experience with it will probably comment. But at the end of the day, I think it just speaks to the variation that you can actually expect in certain population. For example, you can't really distinguish the features, the features in an African population and the other population because of that subjectivity. But I think with phase-to-gene, probably because it's more objective, just I don't know if the algorithm that they use, if it's been tested in the African population, you know, because I think it also depends on the algorithm that has been used to do this dysmorphic checking. But I think probably it's one of the limitations that we see, especially if they have not been algorithms that are used for the African population, then it might not be as useful. But I think the pediatricians who've been who are used, I think it's quite popular, will probably have more experience to sort of give an answer to whether it is reliable in the African population.
Colleagues, we are running out of time. There are many people, Dr. Satekge, who is thanking you for an excellent presentation. I'm not going to read all of it. I think I can give you two more questions, maybe one comment here from, oops, what happened now? Tertius Causa saying, thank you for a very good presentation, Dr. Satekge. Are there any challenges you are facing in Limpopo with regards to the diagnosis of congenital myopathies? And if so, what can clinicians do to assist?
Yeah, congenital myopathy. So what we see is that congenital myopathy, the common test that they request is the SMA gene. And with the SMA gene, so I think the MSMN one. So basically, in that case, they only testing for the common variant. So there are some patients that get diagnosed that test positive for the common variant, but there's also a huge number of patients that do not get a diagnosis because they test negative for the SMA. And then in those cases, then it's also interesting for me what happens to that group. You know, do they get further testing or what really happens? So, and I know that these other myopathies that actually the NHLS Braamfontein tests for, but I think because of lack of awareness, we don't get those testing. So, but I think what will also help is to do panel testing as well, if it's available. But I can safely say that there are many patients with myopathies that continue to be undiagnosed. So basically, after the SM1 gene comes negative, then we're stuck.
Yeah. Unfortunately, I'm going to have to conclude at this point. If you have more questions or comments, you're welcome to email that to us. We can also put you in contact with Dr. Satekge if you don't have his contact details. I have to just remember to thank Pfizer for sponsoring this presentation. Pfizer does not influence the content, the topic, or the speaker in any way. And of course, the content of the presentation is that of Dr. Satekge. I want to thank you for attending the webinar, and I look forward to seeing you in future. Enjoy the rest of your evenings. Goodbye.
All right. Thanks, Prof. Foster. Bye-bye.